Hello everyone, welcome back to Rapid Revision Part 2. So let's begin guys. A 25-year-old primary gravida female is on lithium for treatment of a psychiatric illness for past 2 years. The most common anomaly seen in the fetus whose mother is on lithium during the pregnancy is. So guys, it's an previous year question. A mother is on the lithium therapy and the side effect in the pregnancy on the lithium therapy will be abstain anomaly. Okay, guys, the teratogenic effect is abstain anomaly in which shape heart we have, guys? We have box-shaped heart. We have box-shaped heart. If I talk about from the pharmacological view, if I talk about the side effects of the lithium, guys, you have to remember it with the lith. L-I-T-T-H, lith. Okay, L is for leukocytosis. L is for leukocytosis. I is for insipidus diabetes. T is tremors. The most common side effect for the lithium is, guys, tremors. T is teratogenic. T is teratogenic, that's abstain anomaly. And H is for hypothyroidism. And H is for hypothyroidism. These are all the side effects of the lithium. Okay, let's talk about the other disorders, guys. If I talk about this PTA, patent ductus arteriosus, it is again an 8 PG guys. This PDA is associated, it's the most common cardiac defect. It's the most common cardiac defect associated with congenital rubella syndrome. Congenital rubella syndrome. There is a triad for this congenital rubella syndrome, guys. You have to remember with a mnemonic C, CD, cafe, coffee day. C is for a cataract. C is for cataract. Another C for congenital heart defect. Congenital heart defect. And D is for deafness. SNHL. Is that okay, guys? So this was all about PDA. And then the treatment from the pharmacological point of view, we have already studied, guys. To maintain the patency, we give alprostadil, prostaglandin, and we also use for the closure, we also use ibuprofen followed by indomethacin. Done, guys. Then the neural tube defects, you already know, guys, neural tube defects due to the deficiency of vitamin B9. And the most common neural tube defect, we have spina bifida. We have spina bifida. Okay, and the sign that we have in spina bifida, we have two signs called as lemon sign or banana sign. They are seen in the cerebellum. Banana sign. And the most common spina bifida, if I talk about with a hairy a bit, it is a spina bifida occulta. It's spina bifida occulta. VSD, guys, is associated with multiple conditions. It's also associated with the gestational diabetes mother. With the gestational diabetic mother having infant of the gestational diabetic mother. Okay, let's move to the next question, guys. So abstain anomaly, and this box-shaped heart is due to the ventricular hypertrophies. Okay, so leukocytosis, insipidus diabetes, I will add a 1 point, guys. Let me add a point here. Insipidus diabetes, you already know it is due to the deficiency of the antidiuretic hormone. Okay, na, guys? It's okay. And this diabetes insipidus, we have three conditions. Either this diabetes insipidus, if it is nephrogenic, if you have a nephrogenic diabetes insipidus, your drug of choice will be thiazides. If you have a central diabetes insipidus, guys, your drug of choice will be desmopressin. Desmopressin. And the next one, guys, if you have a lithium-induced diabetes insipidus, if you have a lithium-induced diabetes insipidus, then your drug of choice will be amiloride. Then your drug of choice will be amiloride, guys. Remember this from the pharmacological point of view. Is that okay? And in pregnancy for the diabetes, we have insulin regular, and an oral hypoglycemics as metformin and glyburide. Let's move to the next question, guys. A female has a previous history of a cesarean section. A female has a previous history of a cesarean section and prolonged labor. She is hypotensive. Fetal heart rate cannot be heard. and fetal parts are palpable superficially, the likely diagnosis is. So guys, the hint in the question is that she is a history of a previous cesarean section. That means there can be the rupture of a previous cesarean scar, and the diagnosis will be the uterine rupture. The diagnosis will be what, guys? Uterine rupture. So let's talk about this, guys. Always remember, whenever there is a rupture case and an abruptio placentae case, the history, the presentation of the patient will be almost same, guys. Fetal heart rate cannot be heard, number one thing. It will be a painful vaginal bleeding, guys. The uterus will be tender. Okay, but how to differentiate if the fetal parts are palpable? If the fetal parts are palpable, your diagnosis will be, guys, uterine rupture. If the question mentions the fetal parts are not palpable, the fetal parts are not palpable, then the likely diagnosis is abruptio placentae. Okay, guys, the fetal parts are not palpable, then the diagnosis is abruptio placentae. And the cause for this abruptio placentae, you already know in the part 1, guys. There is increased blood pressure and trauma. There is increased blood pressure and trauma as the cause. Let me show you the picture of this rupture, guys, so that okay, you can see, guys, in the picture, guys, the fetal parts are palpable here. Okay, the fetal parts are palpable here. But there is a difference between a complete uterine rupture and an incomplete uterine rupture. Let me tell you, guys, this picture is a complete rupture. This picture is what, guys? Complete rupture. You might have heard about another term, uterine dehiscence. What do I mean by this uterine dehiscence or uterine rupture? You already know. In uterine rupture, let me write, guys, in a complete rupture, in a complete rupture, guys, all the layers, including the peritoneum, are torn. All the layers, including peritoneum, is torn. Okay. And in incomplete rupture, if I talk about incomplete rupture, in case of an incomplete rupture, guys, visceral peritoneum is intact. Visceral peritoneum is intact. Visceral peritoneum is intact, and fetus remains inside the uterine cavity. And fetus remains in uterine cavity. That is a difference between a complete and a incomplete rupture. And uterine dehiscence is kind of similar to the incomplete rupture. That means all the layers are not torn. Okay, guys, the visceral peritoneum is still intact and you cannot palpate the fetal parts outside. Okay, guys, but in case of a complete rupture, guys, you can see the fetal parts are palpable outside. And there can be a differential diagnosis of a abruptio placentae, but how do you differentiate it, guys? The fetal parts are not palpable in case of an abruptio placentae. Is that okay? And she had a prolonged labor, guys. That is why there was a previous cesarean scar rupture. Okay. Let's move to the next question. A 35-year-old Gravida 3 para 0 live 0 abortion 2 presented with 20 weeks pregnancy, pain abdomen, USG behind the bedside was done showing the funneling of the cervix. Cervical length is 21 mm. What will be the best management for her? So let's, guys, what is the diagnosis? If I see the diagnosis 21 mm, that is a diagnosis of an incompetent cervix. That is a diagnosis of an incompetent cervix. What do I mean by incompetent cervix, guys? By incompetent cervix, I mean short cervix. What do I mean by the short cervix? When the length of the cervix is less than 2.5 centimeter or less than 25 mm. Maths, you know a bit, है ना? थोड़ा सा maths तो आता ही है. So less than 2.5 centimeter or less than 25 mm. So here the cervical length is 21 mm. And it is a diagnosis of a incompetent cervix. It is a diagnosis of incompetent cervix. Now, if I talk about this incompetent cervix, guys, this is the cause of a second trimester abortion. This is cause of second trimester abortion. This is the cause of second trimester abortion. If I talk about the first trimester cause of the abortion, guys, I will write in the short. 1T is C, chromosomal. Second trimester, it's A, anatomical. Third trimester, it's maternal cause. ठीक है ना? शॉर्ट में मैंने लिखा फर्स्ट ट्राइमेस्टर वी हैव क्रोमोसोमल abnormalities, second trimester we have anatomical conditions, third trimester it can be any maternal causes, it can be diabetes, it can be pregnancy induced hypertension, it can be hypothyroidism, it can be celiac disease, SLE, and all other things. Now if I talk about the second trimester abortions, guys, we have a couple of second trimester abortion causes related to the anatomical causes. We have septate uterus, the most common one. We have septate uterus, we have bicornuate uterus, we have bicornuate uterus, and we have incompetent cervix, and we have incompetent cervix. We have septate uterus, we have bicornuate uterus, and we have incompetent cervix. If I talk about septate uterus, guys, the management is, what is the treatment, guys? The treatment is hysteroscopic resection. Hysteroscopic resection. Hysteroscopic resection. If I talk about the bicornuate uterus, the treatment is Stressman metroplasty. Stressman metroplasty. And if I talk about this incompetent cervix, which is less than 2.7 centimeter, guys, we go for the cerclage. And the most common cerclage we use is McDonald's. Cerclage. It is applied at 12 weeks. It's applied at 12 weeks and removed at 37 weeks. And removed at 37 weeks. So guys, what is the treatment? McDonald's cerclage. So in the question, it was mentioned that what is the best management for her, guys? You go with the McDonald stitch or McDonald cerclage. Cerviprime gel, we don't use, guys. That's the dinoprostol gel. Insert the misoprostol and vaginal tablet. No, why you will insert the misoprostol, guys? She's just 20 weeks pregnant, okay? Then admit bed rest and steroids. No, admit bed rest and steroids we give in case of a placenta previa medical management when it's less than 37 weeks, and that regime there we call as McFay-Johnson regime. Okay, coming questions I'll discuss that also. So guys, done. Understood septate uterus, bicornuate uterus, and incompetent cervix, and remember the managements in a very short way. Okay, and in the workbook I've already given the pictures of those septate uterus, bicornuate uterus. Go through those pictures, guys. Enough. A pregnant lady having 2-year-old child had come for antenatal checkup in the second trimester. Recommended dose of tetanus toxoid. Recommended dose of tetanus toxoid. Okay. So if I talk about, guys, if I talk about the pregnancy vaccination, let me write it here. If I talk about pregnancy, I talk about pregnancy vaccination, guys. If she is a primary gravida, then guys, you have to give 2 doses of tetanus toxoid. If primary gravida, you have to give 2 doses of tetanus toxoid. First dose as soon as possible. First dose as soon as possible. Whenever you will give first dose, guys. Okay. And then, guys, there should be a minimum gap of second dose. Minimum gap should be 4 weeks. Minimum gap should be 4 weeks. And the second dose, guys, 3 weeks. You can give second dose 3 weeks prior to term. 3 weeks prior to term, or in a third trimester. That is a primary gravida. If now she is a multi-gravida, if she's a multi-gravida, guys, then you have 2 conditions. If the last child is less than 3 years, then you will give single booster. If last child more than 3 years, then you will again give 2 doses. Is that clear, guys? So that was all about a pregnancy vaccination. Now a lady having a 2-year-old childbirth, that means she's a multi-gravida, guys. Okay. and she just came for the antenatal checkup for the second trimester, the dose will be, it's a multigravida, less than 3 years, the childbirth, you will give tetanus toxoid booster, TD booster you will give. Okay, guys. So again, it's a very important question, guys. It's a very important question. Pregnancy vaccination, they can ask. Okay. Let's move to the, if the age of the last child would be more than 3 years, for example, 4 years, then tetanus toxoid in 2 doses. If next question, guys, if the division of the fertilized ovum occurs between 9 to 12 days after the fertilization, if the division of the fertilized ovum occurs between 9 to 12 days after the fertilization, name the type of the twins. Again, a very important question, guys, they can ask. So let's discuss the fate of monozygotic twins. Fate of monozygotic twins. Fate of monozygotic twins. So it depends upon the day that cleavage take place. Okay. If the cleavage is between 1 to 3 days, if the cleavage is between 1 to 3 days. So guys, remember Didi, guys, dichorionic, diamniotic. Okay. Remember Didi, dichorionic, diamniotic. Okay. Then the next one, guys, if the cleavage takes place between 4 to 8 days, then remember your Prime Minister, guys, Modi. Monochorionic diamniotic. It's monochorionic diamniotic. Monochorionic diamniotic. If the cleavage takes between 9 to 12 days, if takes place between 9 to 12 days, then remember momos, guys. Monochorionic monoamniotic. Monochorionic monoamniotic. And more than 13 days, you will remember conjoined twins or Siamese twins. Same twins. Is that clear, guys? So depending upon the number of day, guys, remember these shortcuts, they are just meant for the understanding purpose. Okay. Didi, Modi, and Momos. Okay, guys. 1 to 3 days, 4 to 8 days, and 9 to 12 days. So in question, guys, it was a cleavage has taken place, a division has taken place between the 9 to 12 days. Then your answer will be, guys, monochorionic, monoamniotic. Monochorionic, monoamniotic twins. Okay. Dichorionic, diamniotic, guys, we have a sign. Which sign, guys? We have a sign, twin peak sign. Remember, twin peak sign or lambda sign. Okay, guys. Diamniotic and monochorionic or monochorionic diamniotic, we have a sign called as T sign. Okay, how do you remember, guys? I've already discussed in the main class. How do you remember? So remember in that way. Okay. Didi lambi hai, to lambda sign, and Modi before used to sell T, so T sign for a monochorionic diamniotic. Hai na? Let's move to the next question, guys. A 35-year-old lady presents with a gravida 3 para 2 with 37 weeks pregnancy. She has a profuse bleeding. USG showed central placenta previa done at 32 weeks. On examinations, her vitals are stable. What will be the next line of management? What will be the next line of management? Okay, guys. So she is 37 weeks pregnant, guys. She is a case of a placenta previa and she's having a profuse bleeding. And you already know, guys, in placenta previa, we have a painless bleeding. Hai na, guys? In placenta previa, we have which type of bleeding, guys? Painless bleeding. But in abruptio placenta, what type of bleeding we have? Painful bleeding. Okay, so she's having a painless bleeding. The diagnosis you already know is placenta previa. Now, if I talk about the management of this placenta previa, the management of placenta previa differs at different weeks. It's different preterm and different at term. Is that okay? If there is a placenta previa bleeding at 37 weeks, bleeding at term. What do I mean by term, guys? 37 to 42 weeks. Any patient having a diagnosis of placenta previa at term, your answer will be cesarean section. Okay, guys, your answer will be cesarean section. Question number second. If at term now, she is not having a complete placenta previa, okay? She is not having a complete placenta previa, or I can say she's having a low-lying placenta, okay? If at term she's having a low-lying placenta, she's having a low-lying placenta. What do I mean by this low-lying placenta, guys? 2 centimeter away from the os. 2 centimeter away from the os. I'll show you the picture, guys. So you have to, first will be the trial of normal vaginal delivery. Your answer will be trial of normal vaginal delivery. If failed, then you can go with the cesarean section. Is that okay? If you have a placenta previa at 32 weeks, if you have a placenta previa at 32 weeks, or I can say, guys, before the term, pre-term placenta previa, 36 weeks, 35 weeks, 34 weeks, guys, then you will go with the expectant management called as McFay-Johnson regime. क्या करेंगे, guys? McFay-Johnson regime. What do I mean by this McFay-Johnson regime, guys? Resuscitation plus rest. Give steroids, beta-methasone and dexamethasone, guys. You remember 2 doses and 4 doses, है ना? We give this beta-methasone for the lung maturity, okay? And admit the patient, okay, guys? And admit the patient, resuscitation, rest, and give steroids. This is called as McFay-Johnson regime, okay? And if RH negative, give anti-D of 300 micrograms and keep the blood arranged, okay? This all is McFay-Johnson regime when the placenta previa is at 32 weeks. But if she is in the term, your answer will be cesarean section. If you have a posterior placenta previa, guys, the posterior placenta previa, guys, in posterior placenta previa, there are increased chances of cord entanglement. That means increased chances of fetal distress. If asked the best treatment, then it will be again cesarean section. And whenever you see fetal distress or the fetal heart rate less than 100, you will go with the cesarean section. Is that okay? So let's see the question, guys. She is in the 37 weeks. That means she's in the term central placenta previa. The next line management will be, guys, immediate LSCS. The next line management will be immediate lower segment cesarean section, guys. So what is placenta previa? I'll show you from the pictures, guys. This placenta previa. Okay. Directly from the management, guys. Let's see. So if placenta previa bleeding at the term, you'll go with the cesarean section and no PV examination because it will increase the bleeding, guys. If at 32 weeks, you will go with the McFay-Johnson regime. If at term, you will go with the cesarean section. Okay. This is grade 1 placenta previa, guys. It's grade 2. This is a low-lying placenta 2 centimeter away from the os. Okay, 2 centimeter away from the os. I've already discussed that. 2 centimeter away from the os. Okay, and give beta-methasone and dexamethasone for the fetal lung maturity. Okay, and what is the question was asked, guys? Confirmation of the fetal lung maturity. Fetal lung maturity. When there is a presence of phosphatidylglycerol. Presence of phosphatidylglycerol in amniotic fluid is a confirmation of the lung maturity. Confirmation of the lung maturity. You also can go with LS ratio. Lecithin sphingomyelin ratio, guys. L is to S ratio. Okay? So these are the tests for the confirmation of the lung maturity. So placenta previa at term, you will mark immediate LSCS. Placenta previa less than 37 weeks, you go with the McFay-Johnson regime. Posterior placenta previa, if going into the distress, cesarean section. If there is a low-lying placenta, your answer will be first the trial of the normal vaginal delivery. If it failed, then you can go with the immediate LSCS. Next question, guys. Very important again. All the questions that I'm discussing in this part 2, every topic is very important. Okay. A 27-year-old woman with a recent abdominal cramps, vaginal bleeding at 3 months, amenorrhea, goes to the emergency room. Upon examination, the cervix is open with the products felt. The uterus is the size of a 10-week pregnancy. Okay, the uterus is the size of a 10-week pregnancy, and there is a bleeding from the cervical opening. Okay, guys, cervix is open, guys, and there is a bleeding, guys. What is the likely diagnosis? So this is the case of an abortion, but depending upon whether the os is closed, whether the os is open, depending upon the history of the patient, is the patient giving the complete history of the passage of the masses, or if the patient is giving an incomplete history, or in case the patient is giving no history of the passage at all, or if the products are bulging, or if the products are hanging outside, we can diagnose the particular type of the abortion. Okay, so let's discuss, guys. Let's discuss on PV examination findings. You're going with the PV examination. Okay, so if the os is closed, uterine size is equal to the period of gestation. That means everything is normal. Uterine size is equal to the period of gestation. So what type of abortion it is? It is called as threatened abortion. It is called as threatened abortion. Okay, os is closed, uterine size is equal to the period of gestation. There is no change at all. Nothing happened. Such type of abortion is called as threatened abortion. Then the second one will be, guys, if the os is open. Now, if the os is open, products are bulging. Products are bulging, or products are hanging, or products can be seen during the examination. Such type of abortion is called as inevitable abortion. Such type of abortion is called as inevitable abortion. Then the third condition, guys, if the os is open. Then the third condition, guys, if the os is open. Then the third condition, if the os is open. If the os is open and products are felt. Os is open, products are felt with history of passage of some masses. With the history of passage of some masses. Such type of abortion is called as incomplete abortion. Such type of abortion is called as incomplete abortion. Such type of abortion is called as incomplete abortion. Os is open, patient is giving that, doctor, I felt some masses. Okay, I felt some masses passed. Okay, such type of abortion is called as incomplete abortion. Now, if the os is closed, now os is closed. Okay, patient is giving a full history of passage. Patient is saying, I have a history of passage of masses. Okay, and there is a normal uterine size. Remember this, there is a normal uterine size. Then the type of the abortion is, that means the os is closed, the door is closed. Okay, everything, whatever was inside came out. Now the uterine size is a normal uterine size. Such type of abortion is called as complete abortion. Such type of abortion is called as complete abortion. Okay, then the last one, os is closed. Okay, usually no warning sign and symptoms. No warning sign and symptoms. Such type of abortion is called as missed abortion. Such type of abortion is called as missed abortion. So guys, you have to remember two things first. Okay, conditions having the os open. One is inevitable. The second one is incomplete abortion. Okay, guys. So you can rule out the other things. Now, if the products are bulging, okay, if the products can be felt at that time, then the patient is not giving any history, then it's inevitable abortion. And if the os is open, patient is saying that, okay, I have a history of passage of some masses, then it is an incomplete abortion. So here, cervix is open, guys. Okay, so either it can be inevitable or it can be incomplete, because in case of a threatened and missed abortion, we have cervical os closed. So products felt with a uterine size of 10-week pregnancy. So guys, this is an inevitable abortion. This is which type of abortion, guys? Inevitable abortion. Is that okay? Patient is not giving any history of what, guys? Product of masses. Okay, passage of masses. Patient is not giving any history, so the diagnosis is inevitable abortion. Okay, and on PV examination, products are felt, okay, or hanging or bulging. That's it. So remember these on the basis of the PV examination findings. What are the different types of abortions you can answer? Then the drugs you already know for the abortion medical management. We have a mifepristone. We give mifepristone and we give misoprostol. We give these two drugs for an abortion, guys. One will kill the fetus, another will expel the fetus out. Okay, one is antiprogestin and another one is prostaglandin. Is that clear? The causes of the abortion I've already mentioned. What can be the first trimester causes, second and third trimester. Even in the part one rapid revision, I've already discussed about the recurrent abortion, guys. Antiphospholipid antibody syndromes, the antibodies and the treatment of low molecular weight heparin plus aspirin. So all these other things related to the abortion we've already discussed. Okay. So guys, this was all about the abortion. And even further, if you have doubts, you can ping me on my Telegram. You can ask whatever doubts you have regarding OB-GYN, PSM, dermatology, and anesthesia, the subjects that I'm teaching. A 19-year-old girl comes with a 3 months amenorrhea, excessive vomiting, blood pressure 110/70 on per abdominal examinations. Fundal height is 18 weeks. Doctor advised USG. Report showed the picture given below. What will be the management? Okay, guys, what will be the management? So, guys, this is again the PYQ, guys. This appearance on the USG is called as snowstorm appearance. This is called as snowstorm appearance. Okay, or the another name is cluster of grapes appearance. Cluster of grapes appearance. And this type of appearance is seen in, what is the diagnosis, guys? This type of appearance is seen in, your diagnosis will be molar pregnancy. Your diagnosis is molar pregnancy. Okay, and in molar pregnancy, there is an increase, which hormone, guys? There is an increase beta HCG. And due to this increased beta HCG, there is hyperemesis gravidarum. There is hyperemesis. Okay, and that is why the question is mentioning that there is an excessive vomiting. Okay, and this excessive vomiting is due to the increased HCG. Okay, in pregnancy, the maximum peak of HCG is on which day, guys? Remember, this is again a one-liner, 66th day. Okay, 66th day. And what is the disturbance the patient will have? Always remember, guys, with vomiting, there will be metabolic alkalosis. With vomiting, there will be metabolic alkalosis. And with diarrhea, there will be metabolic acidosis. Remember that, guys. So what will be the management? So the management, if I talk about, guys, the management, let's discuss the whole molar pregnancy, guys. This snowstorm appearance is seen in type 1 complete mole. It's seen in type 1 complete mole. It's also called as vesicular mole. Also called as vesicular mole. You will also see hydatiform mole. Hydatiform mole. Okay. In type 1 complete mole, guys, endoduplication occurs. Endoduplication occurs. Okay. And the management of type 1 complete mole will be suction and evacuation. What will be management, guys? Suction and evacuation. The management will be suction and evacuation. After suction and evacuation, you will go with the slow curettage. You will go with the slow curettage. And then, guys, the next step will be do USG to check the retained bits. Do USG to check the retained bits. Do USG to check the retained bits. And then do chest X-ray. Okay. Then to do chest X-ray to rule out lung metastasis. To rule out lung metastasis, because if the choriocarcinoma or if this cancer, if this will go to the lungs, there will be what, guys? Cannonball metastasis. There is a cannonball metastasis or cannonball appearance in the chest X-ray. That is why to rule out that cannonball metastasis, we go with the chest x-ray, and you have to advise the patient to follow up HCG. Follow up HCG for how many months, guys? 6 months. Again, a question asked. Follow up for how many months after the suction and evacuation? 6 months. These are all the MCQs, guys, here to rule out the lung metastasis. Cannonball metastasis is an MCQ. Previous year question, NEET PG, NCI as well. This follow-up HCG is a NEET PG PYQ. Suction and evacuation, the management is a PYQ, guys. This snowstorm appearance is a PYQ. Okay, all the questions I'm discussing in the one question. Okay, guys, suction and evacuation will be the management for the molar pregnancy. Suction and evacuation will be the management for the molar pregnancy. Clear, guys? I hope it's clear. Okay, now let's move to the next question, guys. And due to this slow curettage, always remember the curettage has a complication of a Asherman syndrome. Okay, guys. Don't be scared of the very big questions. The bigger the question is, the easier the question is, because in the big question, there will be a multiple hints. There will be a multiple hints in the question. So let's discuss this question now, guys. A 35-year-old gravida 3 para 2 live 2 with 16 weeks of pregnancy. Okay. She's in the labor room with a blood pressure of 150 by 100. That means already, guys, she is what? She is a case of pregnancy-induced hypertension. Okay. PIH. Increased blood pressure. One hint is increased blood pressure with the labor pains. After 4 hours, she complaining severe pain abdomen in between uterine contractions. Uterus 36 weeks, tender. That means tender uterus. Okay. Fetal heart rate is 100. That means the baby is stepping into the fetal distress. She is 4 centimeter dilated. That means she is not having a proper dilatation. The membranes ruptured, show blood-stained liquor. Amniotic fluid is a red color. Remember the session 1. When I said the red color amniotic fluid is an indication of the antepartum hemorrhage. Which antepartum hemorrhage mainly, guys? Abruptio placentae. Is that clear? She was prepared for LSCS. Baby going into the distress, she was prepared for LSCS on doing laparotomy. This was the uterus. This is the picture of the uterus. All steps are to be done except. So what is your diagnosis? First of all, guys, very easy to crack this diagnosis. The diagnosis is abruptio placenta. The diagnosis is abruptio placenta, and this type of uterus is called as covalier uterus. What do I mean by covalier uterus, guys? Bruised uterus. This is called as bruised uterus. This is called as bruised uterus. So what will be the management, guys? What will be the management of the condition? What will be the management of the condition, guys? So let's discuss this. But the question is mentioning that all are the steps to be done except. All are the steps to be done except. Okay, guys, complete the LSCS. Yes, give oxytocin. Yes, we give oxytocin after that. Deliver the placenta by control cord traction. Yes. Do hysterectomy? No, hysterectomy is not the solution, or hysterectomy is not done in case of a abruptio placentae. It's not done in case of a abruptio placentae. What do I mean by this control cord traction? This is a method by which we deliver the placenta. Brand and Andrews method. Okay, guys, so we have already discussed in the active management of the 3rd stage of the labor. The step number 3rd is the delivery of the placenta. Okay, but how do we deliver the placenta, guys? By control cord traction. We also used one method called as Creed's method, but that method is absolute now because there are more chances of retained placenta beds, and once there are more chances of retained placenta beds, there are more chances of secondary postpartum hemorrhage. Once there is a secondary postpartum hemorrhage, the management of these retained beds is what? Curettage. Once you are going for the curettage, you have a complication of Asherman syndrome. You have patient landing into the amenorrhea. The other name for this Asherman syndrome was uterine synechiae. Okay, guys, this is all related. No any big story, no new stories, guys. This is what you have to remember and get this exam done on the 20th Jan. Okay, so let me discuss the management of the abruptio placenta here, guys. Abruptio placentae. Abruptio placentae. We have 2 types, guys, concealed and revealed. But in OB-GYN, most important, very important is management always. So remember, guys, if you have an abruptio placenta at a term, or preterm. Abruptio placentae at term or preterm. What is the cause, guys? The cause is increased blood pressure and trauma. Increased blood pressure and trauma. Guys, see, you can see the bruised uterus, trauma, and you can see here the blood pressure increase, and even the liquor is a red color. When the amniotic fluid is red color, that is the indication of the antepartum hemorrhage. Okay. So increased blood pressure and trauma. Your management will be normal vaginal delivery. If she's in a preterm, that's obvious, guys. She's not in a labor. She's coming to the emergency and complaining of the painful vaginal bleeding with a tender uterus. Your management will be normal vaginal delivery with artificial rupture of membranes. This artificial rupture of membranes will release the prostaglandins. It will release the prostaglandins, and prostaglandins will induce the labor. But if fetal heart rate is less than 100, or baby is in the fetal distress, or the fetal scalp pH is less than 7.2, then your management will be cesarean section. This is all about abruptio placentae. Antepartum hemorrhage, you have three things, guys: abruptio placentae, placenta previa, and vasa previa. Placenta previa already I have discussed before this question. Now vasa previa, what do I mean by this vasa previa, guys? Vasa previa, I will write here, it's a filamentous cord at os. V for filamentous, V for vasa. Filamentous cord present at os, or splitting of the cord, at os. That is the condition called as vasa previa. Then, guys, to differentiate the bleed, whether it is from the mother's side, or whether it is from the mother's side, or the fetal side, we do a test called as apt test. कौन सा test करता है, guys? Apt test, or Singer's alkali test, the another name. Okay. If it is colorless, if after this test the blood is colorless, that is a maternal blood. And if it is red, bright color, okay, that is a fetal blood. Why? Because the fetal RBCs are resistant to the alkaline denaturation. Okay, guys, the fetal RBCs are the resistant to the alkaline denaturation. But if we go deeper into the vasa previa, type 1 vasa previa, type 2 vasa previa, the management is a cesarean section, guys. But at this level, at FMGE level, guys, they will ask the basic things. They will not go that much deeper. Okay, so you remember this much, that is enough. Okay, and from the antepartum hemorrhage, guys, 1-2 question can be accepted, and that always they ask from the placenta previa and abruptio placenta. And please focus on the management. Please look out for the term, whether the patient is in the term, whether she is in the preterm, or whether she is in the postterm. Okay, look out for the fetal heart rate. Look out whether she is bleeding currently or not. Look out whether she is in labor or not. Okay, these are all the important things. Don't mark immediate LSCS always. I've already mentioned one question in my channel regarding this abruptio placenta. I've got around 30-35 doubts on the same question and same reactions. The students are asking, sir, why not cesarean section? Why vaginal delivery? Okay, guys, if question is not mentioning that the fetus is in the distress, if the question is not mentioning that the fetal heart rate is less than 100, you cannot mark cesarean section in abruptio placenta. The only indication for the cesarean section in abruptio placenta is when the fetal is in the distress, and the fetal heart rate is less than 100. Otherwise, you have to mark normal vaginal delivery with artificial rupture of membranes, because they're going to release the prostaglandins and further induce the labor. Okay, now the next question, guys. A 28-year-old primary gravida, very good question, guys. A 28-year-old primary gravida has delivered the baby. Placenta is still intact. In case nurse forcibly extract the placenta, which complications likely to occur? Okay, guys, so nurse has forcibly extract the placenta. So what will happen? Along with the placenta, there will be upside down of the uterus. Okay, the uterus will come into the fundus cavity. Okay, guys, that condition is called as the diagnosis. The diagnosis is, very good, guys, uterine inversion. The diagnosis is uterine inversion. What do I mean by uterine inversion, guys? Turning inside out of the fundus into uterine cavity. Okay, turning inside out of the fundus into the uterine cavity. Fundus is directly into the uterine cavity. Okay, that's called uterine inversion. Okay, guys, if this is the uterus, this is the placenta, they are forcibly removing the placenta, guys. So it will be like this. Okay, so what will be your management? So first, guys, what will be your management, guys? You have to reposite the uterus as soon as possible. Push the uterus back manually. Push the uterus back manually. So once you are pushing the uterus back manually, the maneuver that we use, the maneuver that we use for the manual reposition of the uterus is called as Johnson's maneuver. Okay, guys, before this uterine inversion, let's discuss about the causes of this uterine inversion. What can be the possible causes that the patient will have uterine inversion? Guys, in the last lecture that I mentioned, that even in the main classes, I've already mentioned that for the separation of the placenta, for the smooth separation of the placenta, we have a layer over there called as Nita Bush layer. We have a layer called as Nita Bush layer. What is this Nita Bush layer, guys? This is a fibrinoid layer. This is a fibrinoid layer, and this layer helps in the smooth separation of the placenta. Now, if this layer is absent, I'm saying if this layer is absent, what will happen, guys? Will there be a smooth separation of the placenta? No. Okay. Such placenta we called as adherent placenta. Such placenta we call as adherent placenta. Then depending upon the degree, guys, it can be increta, it can be accreta, it can be parcreta. Okay, what do I mean by this increta, accreta, and parcreta, guys? This is increta, accreta, and parcreta. Okay, this is the accreta, this is increta and parcreta. Once the placenta is attached to the uterine muscles over there, can you see, guys? It's attached to the uterine muscles over there. It will be very difficult to take the placenta out. And once you are trying a forcible, you are putting the force on removing the placenta, the complication that occurs is called as uterine inversion. Okay, so parcreta is having a lot of complications. It can cause a lot of bleeding along with the uterine inversion. Okay, so guys, this is the cause of this adherent placenta is cause of a uterine inversion. Then the second cause can be, guys, sudden cord tractions. Sudden cord traction or the forcibly removal of the placenta can also cause what, guys? Uterine inversion. The next cause also can be the fundal implantation of the placenta. The placenta is implanted in the fundal side. The fundal implantation of placenta. So these are all the causes for uterine inversion. Okay, guys, uterine inversion. If the first thing you have to go, obviously resuscitation, IVX is always the manual reposition of uterus. If you do the manual reposition of uterus, the manual reposition of the uterus is maneuver that we use is called as Johnson's maneuver. Johnson's maneuver. Or if you do the hydrostatic reposition of the uterus, okay, with the normal saline forcibly you're putting, or the warm water you're forcibly putting into the uterus, so that there will be the reposition of the uterus with the hydrostatic method. The maneuver that is called as, the method that is called as O'Sullivan method. The method is called O'Sullivan method. Okay, the MCQ that they can ask from there, the most common cause of death, the most common cause of death in uterine inversion is, my dear students, which shock? Hemorrhagic shock. Which shock? Hemorrhagic shock. But first patient will go into the neurogenic shock. पहले किस shock में जाएगा, guys? Neurogenic shock. Now in the next question I will explain the diagnosis of a conditions going patient into the shock. For example, patient after the delivery going into the shock normally, postpartum hemorrhage. Okay, because even postpartum hemorrhage patient can go into the shock, but very slowly. But in case of an uterine inversion, the question will mention patient is going immediately into the shock. Your answer will be uterine inversion. If the question is mentioning unexplained shock along with the patient is having hypotension, hypoxia, or the coagulopathy, your diagnosis at that time will be amniotic fluid embolism. That's what we are going to discuss in the next question. So guys, this was all about uterine inversion, guys. So what is the question, guys? But which complication is likely to occur? The complication that can occur is acute inversion of the uterus or uterine inversion. Amniotic fluid embolism, I will discuss, guys, how the patient will present, okay? And postpartum hemorrhage, we have already discussed, right? In the part 1. So the answer for this will be acute inversion of the uterus. And the death, the cause of the death is hemorrhagic shock. Drugs for medical abortion. Pharmacological question, guys. You already know the drugs for medical abortion. Yes, both all these drugs we use, but methotrexate has a more common role in which ectopic pregnancy, guys. Okay, methotrexate is a dihydrofolate reductase inhibitor, guys. Okay, having the side effect of cleft palate as well, having the side effect of myelosuppression as well. Okay, anyway, then the drugs that we use for medical abortion is mifepristone 200 mg and misoprostol 800 micrograms. 800 micrograms after 48 hours. So these are the medical abortions, guys. Let me write medical abortion drugs. About this medical abortion, guys, it's 99% successful if done within first 7 weeks. Within 7 weeks. And it's 95% successful if done within first 9 weeks. What are the drugs that we use, guys? The first drug that we use is tab mifepristone. Mifepristone is a which class of drug? Yes. Okay. Yes, it is a antiprogestin. Antiprogestin. What is the function of this mifepristone, guys? It will kill the fetus. It will kill the fetus. And how much you are giving it? 200 to 600 mg. Okay. Then the next drug that we use is misoprostol. The next drug that we use is misoprostol. Prostaglandin E1 give vaginally. Okay, this misoprostol we also use for the induction of labor. Induction of labor, because what is the purpose of this misoprostol in case of an abortion? To expel the fetus out. To expel the fetus out. Okay, and even in the induction of labor, what is our main purpose? So that the baby will come out. Okay, so we also use this misoprostol in induction of labor, but very low dosage. Okay, and the dosage is 800 microgram. Here the dosage is, we start with a 25 microgram. Okay, you will learn these things once qualifying the exam and going for the OB-GYN internship rotation, guys. Okay, so 25 micrograms here. So that was all about, guys, abortion drugs, medical abortion. After more than 12 weeks, prostaglandins are the choice. And from the workbook, guys, or any other sources you're studying, go through these conditions that at how many weeks will go for the suction evacuation, we go for the medical abortion, we go for the surgical abortion. Go out and read those things out. Okay, that's very important. A 25-year-old primary gravida presents with a lower abdominal pain and vaginal spotting. On palpitation, tenderness is noted. UPT was positive and beta HCG levels were 1500 international units. USG performed shows no double decidual sign. Okay, guys, very important things, findings. Ek to 1500 international units is the HCG levels, and there is no double decidual sign. One more condition that but adnexal mass was noted. What will be the most appropriate next step in the management? The next step in the management will be, my dear students, what is the diagnosis first? The diagnosis is ectopic pregnancy. What is the diagnosis first? The diagnosis is ectopic pregnancy. The diagnosis is ectopic pregnancy. So guys, I have already mentioned that in the management of the ectopic pregnancy that if the beta HCG levels are less than 5,000, you go with the medical management. And the medical management, guys, what is the drug you give? Single dose methotrexate. We have other drugs as well, guys. So let me discuss this thing first, guys. If there is a double decidual sign present, if double decidual sign is present, this is called intrauterine pregnancy. That means the pregnancy is inside the uterus. This double decidual sign is due to the parietalis and basalis. Parietalis and basalis. Remember, if double decidual sign is absent, then it's a diagnosis of ectopic pregnancy. It's a diagnosis of ectopic pregnancy. Then, guys, remember one more thing, guys. If beta HCG levels are doubling in 48 hours, okay, HCG level doubling in 48 hours, that means intrauterine pregnancy. Doubling in 5 to 7 days, that is ectopic pregnancy. That means prolonged doubling time. And guys, prolonged doubling time is a diagnosis of ectopic pregnancy. Then the management, I will again write management here. I've already discussed in the part 1, guys. If the HCG is less than 5,000 international unit and the mass size is less than 3.5 centimeter, you go with the which management, guys? Medical management. If more than 5,000 international unit, more than 3.5 centimeter, you go with the surgical management. But if it is ruptured, if ruptured ectopic pregnancy will be mentioned, you go with the salpingectomy. You go with salpingectomy. If unruptured, surgical management will be salpingotomy, salpingostomy, or milking of tube. The drugs, medical management, you use methotrexate, mifepristone, actinomycin, and KCL. For that particular topic, go and watch part 1. If you've already watched, that's got, okay, salpingectomy. Let's move to the next question, guys. Okay, a pregnant female presented to emergency with the complaints of abdominal pain and vaginal bleeding. On examination, cervical os was closed. Guys, os is closed. Okay. And no prolapse of products. Os is closed. Door is closed. She's not giving any history of a prolapse of the products. Fundal height corresponding to the gestational age. Everything is normal. Uterine size is equal to the period of gestation. What is the likely diagnosis, guys? What is the likely diagnosis? The first moment when the question was mentioning os was closed, that means this is rule out, this is rule out. Yes or no? Yes, because in these two conditions, os is open. Then difference, complete and threatened abortion. In complete abortion, guys, patient is saying os is closed, but she's giving the history of the passage of masses. She's saying I felt the fleshy masses coming outside. I had a big heavy bleeding and all, but there is no prolapse of products here. So, and moreover that uterine size is equal to period of gestation, guys. Which type of abortion is that? Threatened abortion. Which type of abortion? Threatened abortion. We have already discussed all the abortion conditions, guys. We have already discussed everything related to the abortion in the previous topic. Remember, guys, we have two signs in ectopic pregnancy also called as Cullen sign. Okay, ecchymosis on the umbilicals or on the flanks called as Gray-Turner sign. These two signs we also see in pancreatitis, guys. But in pancreatitis, my dear students, in pancreatitis, we have other signs as well. Ecchymosis of the scrotum, ecchymosis of the inguinal region, and a Byrand sign, Fox sign. But Cullen sign and Gray-Turner sign are also seen in ectopic pregnancy. So, guys, this question, guys, os is closed, no prolapse of products, and uterine size is equal to the period of gestation. Your diagnosis is threatened abortion. Drugs of abortion already discussed. Let's move to the next question, guys. A lady suffering from diabetes mellitus delivered at term. An infant of the diabetic mother is at the risk of all the following conditions except okay, guys, respiratory distress syndrome, hyperglycemia, hyperbilirubinemia, caudal regression syndrome. Okay, guys, so remember, guys, in case of a gestational diabetes, one hint I will give you that there is always a delayed lung maturity. Okay, so there can be the chances that the patient can go into the respiratory distress syndrome. But let's discuss all the GDM fast. We have already discussed it before. GDM occurs more than 24 weeks onwards. How many weeks onwards? More than 24 weeks onwards. If I talk about PIH, pregnancy-induced hypertension, that is due to the incomplete trophoblastic invasion, and it occurs at more than 20 weeks onwards. Now, which two hormones are responsible for this GDM? HPL and estrogen, because they have a which action, guys? Insulin-like action, further causing the insulin resistance. Okay. Now, after that, guys, if the patient is already having the diabetes, from the starting of the pregnancy, that we call as overt diabetes mellitus. That we call as overt diabetes mellitus. Now, I have told you guys, the mother, the infant of the gestational diabetic mother will be hypoglycemic. Will be what, guys? Infant will be hypoglycemic. Infant will be hypoglycemic. Why it will be hypoglycemic? Because there is a hyperplasia of the beta cells of pancreas. There is a hyperplasia of beta cells of pancreas. Okay, so the answer will be, guys, hyperglycemia. Rather, the baby will be having hypoglycemia. Caudal regression syndrome, if I talk about, yes, guys, the most common neural tube defect associated with gestational diabetic mother, okay, guys, is sacral agenesis. कौन सा है, guys? Sacral agenesis. And the another name of sacral agenesis is caudal regression syndrome. Caudal regression syndrome. The other neural tube defect also associated is anencephaly, okay, which occurs on the failure of 25th day. And the sign we have is a frog eye sign in anencephaly. So these are this is all about a neural tube defect. If I talk about a cardiac defect, my dear students, if I talk about the cardiac defect that is associated is transposition of great arteries followed by VSD. But the first will be transposition of great arteries. On chest X-ray, X-ray पे कौन सी sign दिखेगी, guys? X-ray पे कौन सी sign दिखेगी? Egg on string appearance. Egg on string appearance. If I talk about box-shaped heart, that will be Epstein anomaly. Boot-shaped heart, that will be tetralogy of Fallot. Figure of 8 or snowman. Figure of 8 or snowman, it will be TAP VC. These are all the important conditions, guys, from the pediatric point of view. Any more, guys? Reverse 3 sign. Okay, guys. Coarctation of aorta or overriding of aorta. Okay, these are all the important signs that you have to remember. Okay, so anencephaly, frog eye sign. This was all about GDM. The drugs that you give is insulin, regular, and orally. If you write metformin and glyburide. Metformin is a which class of drug? Bigivenides. Glyburide is a sulfonylurease. If from the pharmacology, the question will be asked, what is the side effect of metformin? It's lactic acidosis. And for glyburide, it is it's hypoglycemia. Okay, guys, it's hypoglycemia. Next question, guys. A 30-year-old primary attends the antenatal clinic at a period of amenorrhea of 35 weeks. She has a single fetus in breech presentation. Ultrasound scan confirms presentation, guys. No other abnormalities are detected. What is the next step in the management of the normal vaginal delivery? Okay, guys, she is 35 weeks pregnant, guys. Okay, she's at 35 weeks. She has a single fetus, but she's in which presentation? Single fetus, कौन सी presentation है, guys? Breech presentation. Ultrasound scan confirms the presentation. Okay, it's confirmed. No other abnormalities are detected. So what will be the next management? What will be the next management, guys? Okay, so guys, I've already told you, if you have a breech presentation, moving to our main class discussion, breech presentation at term in labor. Okay, guys, breech presentation at term in labor or breech presentation in labor, your management will be always cesarean section. What will be your management, guys? Cesarean section. Number one thing. Number second thing, guys, if not in labor, around 37 weeks, if she's in 37 weeks and she's not in labor, your answer will be ECV, external cephalic version. Okay, guys, external cephalic version. So ECV you have to do, guys, 36 weeks onwards. but the condition will be she must not in labor. Not in labor. If labor, guys, you have to do the cesarean section. If now a breech presentation comes at 32 to 34 weeks, okay guys, 32 to 34 weeks, guys, then no external cephalic version, because there is an increased amniotic fluid or there is an increased liquor, and baby will change its prior position. Baby will change its position. So my dear students, see, you have a patient coming to you. Okay, she's a breech presentation and she's coming to you at 37 weeks, but she's not in labor. So your answer will be external cephalic version. You go with the external cephalic version because the amniotic fluid keeps decreasing after 36 weeks onwards. So even if you go with the external cephalic version, the baby will not change its position. Are you getting my point? But if the same patient is coming to you at 32 weeks and you know during 34, 33 weeks, 35 weeks, the amniotic fluid is at the peak. So there is a very huge amount of amniotic fluid. Even if you go for ECV, what will happen, my dear students? The baby will keep changing its position. The baby will dance inside the uterine cavity. Are you getting my point? It's the same example. You're putting a ball in the tub, having a full water. So what will happen to the ball? It keeps rolling, 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 dancing. But if there is a very less water, so what will happen? Will it change its prior position? No, it will not change its position. So the condition of the breech presentation is, guys, if the patient is in labor, mark cesarean section. If not in labor, so go for the ECV at 36 weeks onwards. Okay, guys, 36 weeks onwards. So here, what will be your answer, guys? She's currently at 35 weeks. Breech presentation. What is the step? Next management, guys, will perform an external cephalic version at 36 weeks. Okay, we cannot induce if not delivered by 47 weeks. Go, guys, we have to always choose the first option. Okay, that is a later option if you'll not go for the ECV. The first option here, you have to go with the 36 weeks external cephalic version. External cephalic version. So for the breech presentation, is that okay? Then, guys, breech presentation, we have frank breech, complete breech, incomplete breech, and footling breech. Okay, frank breech is the most common one, and among all the breech presentations, which we will go with the cesarean section without confirm, that is a footling breech. Okay, guys, footling breech. Then we have maneuvers for the breech as well, guys. We have Pinard's maneuver. Yaad rakhna, guys, Pinard's maneuver for extended legs. We have Lauset's maneuver for extended arms. We have Bern-Marchand technique or Retigen maneuver for head. Okay, na? And which forceps we use, my dear students? Piper's forceps. So that was all about this, guys, presentations. A primary gravida at 37 weeks gestation reported to the labor room. Marginal posterior placenta previa. Already discussed, guys. Posterior placenta previa are more chances of cord entanglement, more chances of fetal distress. So the best management will be with the painless bleeding per vaginum. Okay, painless bleeding associated with placenta previa, painful bleeding with abruptio placentae. The fetal heart rate was normal at the time of examination. At the time of examination, it is normal. But the best management option for her, will be, guys, cesarean section. The best management will be having cesarean section. Why? Because posterior placenta previa. Okay, there are more chances of cord entanglement. So there are further more chances of fetal distress. So best managed by cesarean section. The sign in placenta previa, it's called as stall-worthy sign. Remember this sign, stall-worthy sign. And you have to advise this patient, guys. We have to advise this patient continuous fetal surveillance. Continuous fetal surveillance. Continuous fetal surveillance. Next question, guys. Drug of choice in postpartum hemorrhage resistant all routine drugs. If in PPH, drug of choice resistant all routine drugs, it will be carboprost. It will be which drug, guys? Carboprost. If I talk about carboprost, guys, it's PGF F2 alpha. Okay, the dosage is 0.25 mg. The maximum of 8 doses you can give. The PYQ in the NEET PG, what is the dosage of this PGF2 alpha? It is maximum dosage is 2 mg. It's the most potent drug. It is the most potent drug and the injectable drug. It's the most potent drug and it's a injectable drug. Is that okay, guys? After that, we use tamponades in the BPH, है ना? We use Buckley's balloon, we use Foley's catheter, or we can also use the cheap, guys, condoms. Is that okay? Then we go for the compression sutures, guys. Compression sutures में कौन सा sutures है? Brace and Heyman sutures. It's already discussed. Then the order of the artery is ligated. It's uterine artery, my dear students, followed by ovarian artery, followed by internal iliac artery. Which branch of internal iliac artery? Anterior branch of internal iliac artery. But the best management will be, my dear students, hysterectomy. The best management will be hysterectomy. If I talk about dinoprostone, guys, it's a gel used for induction of labor. Methyl ergometrin, yes, it is used, but it is not a resistant to all routine drugs. It's not more potent, but we have a contraindications for that. You have to remember PIH, you have to remember RH incompatibility and heart diseases. And misoprostol also we use. All the except dinoprostol, all the drugs we use in postpartum. But if resistant all routine drugs, then the answer will be carboprost. The answer will be carboprost. Guys, I was a bit fast in this question because the reason is we've already discussed that question in the part 1. Woman had 3 consecutive abortions in second trimester. What should be the best method to manage her condition? Okay, she's having second trimester abortion. So second trimester abortion, my dear students, is it directly hint what is the cause? It is anatomical cause. It is which cause, my dear students? Anatomical cause. What can be the anatomical cause? It can be septate uterus, it can be bicornuate uterus, it can be incompetent cervix. Now the question is mentioning that what will be the best method to manage her conditions, guys? The best method to check the patency of the tubes, we go with the hysteroscopy and laparoscopy. So the best will be, guys, hysterolaparoscopy, guys. So to check the patency, of the tubes, and anatomy of the tubes, we go with hysteroscopy plus laparoscopy. Hysterolaparoscopy. Now, sir, we can also check the anatomy and patency with the hysteroscopy. Why laparoscopy? Because laparoscopy alone will rule out the adhesions. Why there can be adhesions? Because of the endometriosis. Also there can be adhesions. That is why the treatment for adhesions was adhesiolysis. And what was the investigation of choice for endometriosis? It is laparoscopy, so adhesions can also be there, and to rule out the endometriosis, laparoscopy. Is that clear? So hysteroscopy and laparoscopy. Chromosomal analysis will do in case of a first trimester abortion, my dear students, and performing a McDonald circulage will be for the incompetent cervix. वो हमने already discussed किया when the cervix is short. Hysteroscopy alone, yes, we can use, but the question is mentioning the best. The best will be hysterolaparoscopy. Next question, my dear students. Chorionic villus biopsy is done in all of the following, except. Yes, guys, these are the chromosomal condition or the first trimester conditions. We use mainly chorionic villus biopsy. Okay, Down syndrome, myotonic dystrophy of the CDG repeat, chromosome number 21, Down syndrome, guys. Okay, in such conditions, we use the chorionic villus biopsy. But if I talk about neural tube defects, my dear students, for neural tube defects, we check the amniotic fluid, and if there is a presence of acetylcholinesterase, in amniotic fluid. That is the confirmation of neural tube defect. So chorionic villus biopsy, we go for amniocentesis. हम क्या करते हैं उसमें guys? We go for amniocentesis rather than going for chorionic villus biopsy. Okay, and the presence of phosphatidylglycerol in amniotic fluid. If there is a presence of phosphatidylglycerol in the amniotic fluid, that is a confirmatory of the fetal lung maturity. And if the fetal lungs are not matured, we give beta-methasone and dexamethasone. So remember guys, for neural tube defects, what is the confirmatory test guys? You do acetylcholinesterase in amniotic fluid. Is that clear? Rest we go with the chorionic villus biopsy. Now, magnesium sulfate has no role in prevention of. Magnesium sulfate has no role in prevention of seizures in severe preeclampsia. Yes. Seizures in eclampsia. Yes. It's a neuroprotection. Yes. Respiratory distress syndrome in premature baby. No, we don't use for that. So let me write it here, guys. Magnesium sulfate, my dear students, we use 4 to 7 milli equivalent. How much, guys? 4 to 7 equivalent. It is a drug of choice for eclampsia. It is a drug of choice for eclampsia, pre-eclampsia also. Okay. Now, what is eclampsia, guys? I've already discussed what is eclampsia. It is pre-eclampsia plus convulsions. It is pre-eclampsia plus convulsions. What do I mean by pre-eclampsia, guys? Pre-eclampsia is when the blood pressure is more than 140/90, plus there is a proteinuria, plus there is a in preeclampsia there is blood pressure more than 140/90 plus proteinuria, but in eclampsia, preeclampsia plus the convulsions. And what is gestational hypertension, guys? More than 20 weeks, blood pressure is more than 140/90. That is gestational hypertension. And there is a one more term, my dear students, called as delta hypertension. What do I mean by this delta hypertension? Delta hypertension means throughout the pregnancy the blood pressure is normal, but in the last week it is sudden increase in the blood pressure. That hypertension is called as delta hypertension. Then there is a chronic hypertension associated with the pheochromocytoma or the renal artery stenosis. Okay? That is a chronic hypertension. Remember these definitions, and I've already discussed this chapter as well in the part 1 of the rapid revision. So guys, it's a drug of choice for eclampsia, preeclampsia. It is a neuroprotective. It's neuroprotective, yes, but not used in RDS. We use this in 2 regimes, guys. 2 regimes, magnesium sulfate. We use 2 regimes. One regime is called as Pritchard's regime. One regime is called as Pritchard's regime. The second regime is called as Zuspan regime. The second regime is called as Zuspan regime. Pritchard is IV plus IM, and this is only IM. The magnesium sulfate, apart from that, it's also used in, my dear students, if the medicine point of view, किसमें use होता है? Ventricular tachycardia, torsades pointus. Okay, VT. But PSVT, PSVT is also a type of a ventricular tachycardia, but in PSVT we use adenosine, है ना? And the first management will be the carotid sinus massage. And this magnesium sulfate is also used as tocolytic drug. Tocolytic drug. But the best tocolytic will be calcium channel blocker, nifedipine. ये भी याद रखना, guys. Best will be nifedipine. Is that okay? So it was all about magnesium sulfate. It was all about magnesium sulfate. Then the next question, my dear students, a primary gravida, and you already know, guys, about the antidote of the toxicity. The first symptom will be the sluggish knee reflex or the loss of deep tendon reflex, and the antidote will be calcium gluconate. And once one will be the sign and symptom started of the toxicity when the dosage is more than 10 milli equivalents. When it exceeds more than 10, then the sign and symptoms of toxicity will be there. A primary gravida is brought home by her relatives just after the 1 hour after the vaginal delivery of a full-term healthy infant. The baby is doing well. Okay, so guys, primary gravida delivered a baby. The baby is well. Okay, on examination. Now what happens in the patient? Patient is hypotensive. Patient is, my dear students, hypotensive. Patient is hypoxic, and disseminated intravascular coagulation. Which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis? My dear student, this is a classical triad. This is a classical triad. Hypoxia, hypotension, and coagulation defect. And coagulation defect is a classical triad of a amniotic fluid embolism. Classical triad of a amniotic fluid embolism. So what is the answer, my dear students? Amniotic fluid embolism. Hypotension, hypoxic, and disseminated intravascular coagulation defect. So hypoxia, hypertension, and coagulation is an amniotic fluid embolism. Now let me discuss a few main points, guys. What happens in amniotic fluid embolism? The fetal debris, fetal cells, they went into the mother's circulation and causing the collapse. So the patient, that's why the patient is complaining of hypoxia and sudden decrease in the blood pressure along the coagulation defects. But now, guys, remember, if the patient after the delivery, goes into shock. Now, patient after the delivery goes into the shock. Your answer will be, my dear students, postpartum hemorrhage. If the patient after the delivery immediately goes into the shock with the no time, patient going into the shock immediately goes into the shock, then your answer will be, my dear students, uterine inversion. Look out to these words, uterine. In PPH, we discuss uterine inversion and discuss if the patient after the delivery goes into unexplained shock, then your answer will be, my dear students, amniotic fluid embolism. Your answer will be amniotic fluid embolism. Okay? Amniotic fluid embolism. So remember this amniotic fluid embolism, guys. Patient having a hypotension, hypoxic, and disseminated intravascular coagulation. Okay. Then we have other embolisms as well in the medicine. Whenever you see a fracture of long bones, जब भी देखोगे fracture of long bones like femur, which embolism is there, my dear students? Fat embolism. Patient is having a history of DVT, or patient is having a pelvic surgeries. Which embolism will take place, my dear students? Pulmonary embolism. I don't want to go deeper, guys. Then which criteria we have for fat embolism? The name of the criteria in the fat embolism, we have GERD criteria. What is the criteria in the pulmonary embolism? And in pulmonary embolism, we have modified Wells criteria. Hai na, guys? And on the ECG, we have S1, Q3, T3. On echo, we have McConnell sign, and most specific is sinus tachycardia in pulmonary embolism. And we advise patient to taking low molecular weight heparin. These, remember these things, guys. It's a very important, this embolism. Then on deep divers, we have ear embolism as well. So remember such conditions. So guys, patient was after the delivery complaining of hypotension, hypoxic, and coagulation defects. The answer is amniotic fluid embolism. Okay. Let's go to the next question, guys. A 25-year-old female with a history of 2 weeks amenorrhea came in emergency with the complaints of scanty vaginal bleeding. On examination, no adnexal mass was noted. In lab investigations, HCG was 1400. On USG, uterus was bulky. Trilaminar endometrium was seen. Patient's vital are stable. What is the next step to do, guys? So on USG, guys, she's just having a 2 weeks amenorrhea. So you can have a differential diagnosis of ectopic pregnancy. But how do you check further, guys? We already discussed. You have to repeat the beta HCG after 48 hours. After 48 hours. If it is doubling in 48 hours, it is intrauterine pregnancy. Doubling in 5 to 7 days, it is ectopic pregnancy. It's ectopic pregnancy. Is that okay? So guys, let me discuss here some important drugs in the pregnancy. Let me write drugs in pregnancy. Okay. If we talk about, first of all, my dear students, thyroid For, my dear students, thyroid, for hypothyroidism. For hypothyroidism in pregnancy, we give L-troxin. We give L-troxin or levothyroxine. L-troxin or levothyroxine. For hyperthyroidism, for hyper, what do I mean by hyper, guys? Decreased TSH. There is a negative. Hypo में क्या होता है? Increased TSH. For hyperthyroidism, first trimester you give PTU. First trimester. Then second and third trimester, my dear student, you give carbimazole. You give carbimazole and methimazole. If you give carbimazole and methimazole in the first trimester, what will happen? What is the side effect of that? The side effect is aplasia cutis. The side effect is aplasia cutis. Number one thing. If I talk about antibiotics that we use in the pregnancy, my dear students, we use 3 antibiotics: PCM, we use penicillin, we use cephalosporin, and we use macrolides. Except we don't use erythromycin. Erythromycin क्या कराता है guys? Erythromycin can cause congenital hyperpyloric stenosis, CHPS, है ना? Then you already know CHPS, non-bilious vomiting, male baby, metabolic alkalosis, hypokalemic, hypochloremic, Ramstead surgery is the surgery for that, है ना? CHPS, you have studied that. So remember, erythromycin नहीं देते हैं. If I talk about anticoagulants, mainly what is the anticoagulants we use, guys? Heparin. Okay. If I talk about toxoplasmosis in pregnancy, guys, we use paramycin. But mainly, if non-pregnant, we use leucovorin, sulfazidine, and one more drug we use in case of a toxoplasmosis. Okay, is that clear? Then, guys, for malaria, we use what? Quinine. We use quinine. My dear students, if I talk about epilepsy, हम क्या use करते हैं? Lamotrigine or levetiracetam. Okay, remember these all the drugs. And for UTI, क्या use करते हैं? Nitrofurantoin. Okay, so these are the drugs in pregnancy. Please go through the pharmacology as well. A 28-year-old woman has been on OCPs for 5 months. She presents to the OPD with a 6-week amenorrhea and her UPT is positive. Which of the following is the most accurate method to determine the gestational age in the woman? So guys, she was using OCPs for the 5 months, but she's having a 6 weeks amenorrhea. That means in the first trimester. And the best parameter to check the estimation of the fetal age on the first trimester, my dear students, is crown rump length. It's crown rump length. So let's discuss best parameters for estimation of fetal age. Best parameters for estimation of fetal age. My dear students, if I talk about first trimester, that is crown rump length. If I talk about second trimester, that is bipyramidal diameter. If I talk about third trimester, my dear students, that is femur length. If I talk about overall best, सबसे best, that is crown rump length. So guys, on the first trimester, your answer will be crown rump length. Okay, then counting the days from LMP, guys. If we let me tell you about a Nagli's rule here, guys. Okay, to check the estimated date of the delivery, EDD के लिए, okay, the formula is 9 months plus 7 days, but that is for the regular cycle. NEET PG question, guys, they can play with you. Regular cycle is 28 days. Now if in a question it's mentioned, for example, today, what is the date today, guys? It's 19th December. So now if the question, the patient will it will be mentioned that the patient had a LMP of the 19th December. Patient had a LMP of 19th December. So they will mention, guys, what will be the EDD if the cycle is 32 days. Her cycle is 32 days. Then at that time, you have to do 9 months plus 7 days plus 4 days. Then this will not work. This will only work for the regular cycles. Okay. And if they will mention that the cycle is only 26 days, then you will subtract the two. Then you will subtract the two. So Nagli's formula for EDD, guys. One question can be asked over there. Then, guys, fundal height, remember mainly PUX. Pubic symphysis at 12 weeks, umbilicus at 24 weeks, cephus sternum at 36 weeks. If it is lower border of umbilicus, that it's 20 weeks, guys. It's 20 weeks. Let me show you that also. That is very important as well. I'm not able to find that. Okay, guys, that I will post in my channel. One particular image that at how many weeks, what will be the fundal height according to the weeks. So it will be, that's not mentioned here. Anyway, guys, I will mention that at 12 weeks, it's pubic symphysis. At umbilicus, it's 24 weeks. Upper border of umbilicus is 24 weeks, guys. Okay, lower border of umbilicus is at 20 weeks. Cephus sternum is 36 weeks, guys. This abdominal lag, if there is an abdominal lag, my dear students, this helps in the diagnosis of the this abdominal lag helps in the diagnosis of the IUGR. Okay, IUGR में क्या होता है? We check the clinically if there is a lag in this abdominal lag. We suspect that it is IUGR if it's not as per the weeks. Anyway, let's move to the next question, my dear students. A 35-year-old woman is a chronic hypertensive. She visits the clinic for preconception counseling. Which of the following antihypertensive needs to be stopped prior to conception? So let's discuss, my dear students, antihypertensives that we used. Antihypertensive in pregnancy. So already you know, guys, what is the cause of hypertension in pregnancy, guys? It's due to the incomplete trophoblastic invasion. What do I mean by incomplete trophoblastic invasion? Incomplete trophoblastic invasion means that the resistance of high vessels is not replaced by the resistance in the low vessels. So I've told you that at 20 weeks onwards, what happens? There's a trophoblastic invasion. Okay, these high resistant vessels will be replaced with the low resistant vessels. But once there is no trophoblastic invasion, the resistance in these vessels will remain high, okay, causing the pregnancy-induced hypertension or the vasospasm. Okay, so now if we talk about the drugs, the first line drugs that we have, my dear students, first is labetalol. Labetalol is alpha plus beta blocker. You can give up to 240 mg, guys. It comes with a trade name label. Whenever you see blood pressure anyone having increased blood pressure, prescribe 20 mg label. कुछ नहीं होगा उससे, ठीक है? Labetalol. Okay. The second drug is alpha methyl dopa. Okay, that is a pro drug. Then the third one is a calcium channel blocker, nifedipine. Nifedipine is also a best tocolytic drug. Then we also have alpha blocker, prazosin. Okay, that is a safe in that's a safe for hypertension in pregnancy. And also we have hydralazine arteriolar dilator. We also have hydralazine arteriolar dilator. Okay, guys, this prazosin has a side effect, guys. Remember, I will write it here. It's a side effect as tremors and orthostatic hypotension. Guys, this prazosin is also used in benign prostate hyperplasia. Remember, this prazosin is also used in scorpion sting. I don't want to go deep into the pharmacology, guys. Let me stick to the obstetrics only. We'll do that some other day, the rapid integrated revisions. Okay. So remember orthostatic. If I talk about orthostatic hypotension, the drug is midodrine. Pulmonary artery hypertension, the drug is bosentan. Remember these things. So here, just remember these 5 drugs, guys: labetalol, alpha methyl dopa, nifedipine, prazosin, and hydralazine. So out of the following, which drug is stopped prior to conception? ACE inhibitors are stopped. They can cause, guys, what is the side effect of ACE inhibitors? We have angioedema. Along with that, my dear students, we have renal artery stenosis. If the patient is taking, and it can also cause vasospasm, renal artery stenosis. This renal artery stenosis can further lead to oligohydramnios, because most common cause of oligohydramnios is bilateral artery stenosis or renal agenesis, है ना? Oligo, when the AFI is less than 5. Okay, so which drug you have to stop, guys? ACE inhibitors. Rest all the drugs can be given. The drug of choice will be, if there is a emergency, अगर emergency में increase blood pressure in pregnancy, you give IV labetalol. My dear students, if IV labetalol is not mentioned, then mark IV hydralazine. That is for the emergency. But in case of oral drugs, first you will mark labetalol. If not, then alpha methyl dopa. But emergency may IV labetalol, and then the backup is IV hydralazine. So that was all about this question. Let's move to the next question, guys. A 25-year-old primary gravida presents at 36 weeks with a labor pain and vulval ulcers. She does not give history of the similar lesions ever in the past. On examination, there are multiple painful vesicular lesions. What is the best treatment? So, guys, what is your diagnosis, guys? It's herpes simplex virus, guys. You already know drug of choice is acyclovir, and we'll go with the elective cesarean section. Why, guys? So that the virus will be not transmitted to the baby, guys. Okay. And HSV, what is the drug of choice, guys? It's acyclovir. It's acyclovir. So acyclovir and lower segment cesarean section. Is that okay? Next question. A 25-year woman presents to the antenatal OPD. This is her second pregnancy, and her first pregnancy was 4 years earlier, where she delivered a twin at term. What is the parity index? What is the parity index? So, guys, there are different couple of definitions. First of all, G. What is G, guys, my dear student? G is gravida. G से क्या होता है? Gravida. Okay. So, what is gravida? It denotes a pregnant state. It denotes a pregnant It denotes a pregnant state, both present and past. That means how many times she was pregnant, okay? Or number of times pregnant. Or number of times pregnant. Denotes a pregnant state, past and present. Or you can mention, guys, number of times pregnant. So she was pregnant how many times, guys? It is her second time. So already, guys, P1, P3, G3, P1 and G3, P2 are gone because she is second time pregnant. Doesn't matter she delivered twins, she delivered triplets in the previous pregnancy, but guys, she is pregnant for the second time, second pregnancy. So the gravida is 2. Now, my dear student, then the parity. Parity denotes the state of previous pregnancy beyond the period of viability. Again, irrespective of the triplets, irrespective of the twins. Okay. So what is parity? Denotes a state of previous pregnancy beyond the period of viability. So that is 1. So here, guys, it's gravida 2, para 1. Then sometimes you will see, guys, it's also mentioned live 2, abortion 1. L is live, how many children are live currently. Abortion is how many times she had an abortion. Okay. So for abortion, if she's giving the history of abortion, for abortion is total number of abortions or miscarriage. Total number of abortion or miscarriage. Total number of abortion or miscarriage, or ectopic pregnancy, before 24 weeks. Before 24 weeks. So here, guys, simple question, gravida 2, para 1. Abortion is how many abortions she will give in the history, and live is how many children are currently live. So gravida 2, para 1 here is a parity index. Okay. Then a 55-year lady with 5 children present with a leakage of the urine. on cuffing. On examination, there is a second degree uterine prolapse and cystocele. What is the most likely urinary abnormality? So guys, your diagnosis is what, guys? Due to the stress, if she's having the leakage of the urine, if she's having the leakage of the urine which coincides with the stress, for example coughing, for example sneezing. Are you getting my point? The diagnosis is, my dear student, stress incontinence. Kya hai diagnosis, guys? Diagnosis is stress incontinence. Stress incontinence. What happens, guys, when the patient is having the uterine prolapse? जब patient को क्या होता है, my dear students? Uterine prolapse. So this uterine prolapse will involve two things also. It will involve bladder, my dear students. It will involve the rectum, yes or no? If it involves the bladder, it will give the symptoms of cystocele. If it involves the rectum, it will give the symptoms of rectocele. अब जब cystocele rectocele भी आ गया, ठीक है, so what will be your management? You are tightening the anterior. For cystocele, you are going for anterior colporrhaphy, and for rectocele, you are going for posterior colporrhaphy. It's together is called as pelvic floor repair. This together is called as pelvic floor repair. So if she's having a uterine prolapse, you already have told you there will be the features of the cystocele, and she's having this, guys, on cuffing, she's having a leakage of the urine. Such condition is called as stress incontinence. Such condition is called as stress incontinence. Okay. And the treatment, if I talk about, the best treatment for stress incontinence is tension vaginal tape. You tighten the anterior vaginal wall, tension vaginal tape. We also go for bladder neck plication. We also go for the pessary ring. But the best, my dear student, is TVT. You also go for Birch Colpo suspension. Colpo suspension. I've discussed all these things in the part 1 as well. Please go through them, or either go through my workbook, guys. Learn this. Okay. Then it depends upon the prolapse. If prolapse is taking in place in the young woman, we go for Manchester repair or Fothel grip repair. If in a very nulliparous ladies, very young ladies, guys, we go with the sling surgeries. We go with the sling surgeries, right? Shrodkars, Khannas, and all. Is that clear? So, guys, the answer is here is stress incontinence. And about the stress incontinence, patient is fully aware. Patient is fully aware about that. And what is stress incontinence, my dear students? It's a leakage of urine which coincides with the stress. A 25-year married female who is anxious about her conception comes to the OPD with the complaints of profuse vaginal discharge. She is having the discharge, but there is no history of itching and her cycles are regular. The most likely diagnosis is, guys, she's anxious, okay, and she's complaining with the vaginal discharge, but there is no itching, there is no foul smell, there is nothing. Her cycles are regular. So what is your diagnosis, guys? The diagnosis is leukorrhea. The diagnosis is leukorrhea. What is leukorrhea, my dear students? It's excessive normal vaginal discharge. It's excessive normal vaginal discharge. It's excessive normal vaginal discharge. Okay. Then this excessive normal vaginal discharge, it is physiological. It is physiological. Okay. It is never associated with pruritus. Never associated with pruritus. Are you getting my points? It's non-irritant. It's non-irritant. Is that okay, guys? It's non-irritant or non-purulent. It's non-irritant or non-purulent. Is that okay, guys? Non-irritant or non-purulent. Okay. About candidiasis, my dear students, you have which type of discharge? Curdy discharge. Okay. Which discharge we have? Curdy discharge. We have curdy discharge. And what is the drug of choice for candidiasis? We have fluoroconazole. We have fluoroconazole. For trichomoniasis, my dear students, we have greenish discharge mainly. Which discharge? Greenish discharge. But this greenish discharge, along with that, my dear students, we have which vagina? We have strawberry vagina. And this strawberry vagina, my dear students, is associated with trichomonas. Okay, trichomoniasis. This is also called as, this strawberry vagina is also called as colpitis. This is also called as colpitis macularis. This is also called as colpitis macularis. The drug of choice for that condition will be metronidazole. Trichomoniasis में क्या देंगे guys? Metronidazole. And both partner is treated. Both partner is also treated. Then the last one, my dear students, bacterial vaginosis. It's caused by Gardnerella. Okay, it's the most common vaginitis. I'm repeating this because this is a very important. Most common vaginitis. You have a criteria called as Amsel's criteria. What is the criteria name, my dear students? We have Amsel's criteria. What do I mean by Amsel's criteria, guys? It's Swift test positive. We have a clue cells. We have whiff test positive. We have clue cells. We have creamy discharge. We have creamy discharge. And my dear students, the last one, we have fishy odor. We have fishy odor. This all is about which criteria, my dear students? Amsel's criteria. And about Amsel's criteria and about the drug of choice, sorry, for this bacterial vaginosis, also metronidazole. Also metronidazole. So leukorrhea is a physiological. Is that clear, guys? This question. Now let's move to the next question. A 12-year-old girl is brought to the OPD by her mother. She's concerned that she's shorter than her peers. On evaluation, which of the following would you expect to find? Okay, guys. So short stature, guys. So what will be your answer? Probable diagnosis mainly? It's Turner syndrome. It's Turner's syndrome. Okay, so ultrasound showing the streak ovaries and a small uterus. So you are suspecting these things. So guys, let's write about Turner syndrome. It's 45XO. Okay, so what are the components we have? We have streak ovaries. We have short stature. We have webbed neck. We have webbed neck. We have hypoplastic uterus. We have hypoplastic uterus. We have shield chest. We have shield chest. And we have primary amenorrhea. We have primary amenorrhea. And also, guys, the heart defect that is associated. The heart defect associated with the Turner syndrome. Remember this question, guys. The heart defect associated is bicuspid aortic valve stenosis. Bicuspid aortic valve stenosis. My dear students, if I talk about Down syndrome, please remember Down syndrome. Down syndrome, a most common cardiac defect that is associated in Down syndrome. The most common cardiac defect that is associated in the Down syndrome is endocardial cushion defect. Endocardial cushion defect. Endocardial cushion defect. Okay, these two heart defects you will remember, guys. Down syndrome and Turner syndrome. One more syndrome, guys. Noonan syndrome. The heart defect, my dear students, you will remember in Noonan syndrome is pulmonary stenosis. Pulmonary stenosis. Also, you will remember over there. Okay, Noonan syndrome. Guys, one more syndrome, Turner syndrome. One more syndrome we have is Klinefelter syndrome. 47XXY. Klinefelter syndrome. Just remember main two things over there, guys. There is a tall stature. And they will mention in the question there is gynecomastia. There is gynecomastia. If we relate a bit, last guys, if we relate a bit gynecomastia with the pharma, we have disco drugs, है ना? D for digoxin, isoniazid, S for spironolactone, C for cimetidine, or K for ketoconazole, or O for estrogen. Gynecomastia causes which drugs, guys? Disco drugs. That is Klinefelter syndrome. Last one, guys, if there is an anosmia mentioned, in a clinical case, that is Kalman syndrome. Anosmia होता है किस syndrome के साथ? Kalman syndrome. So that's all completed, guys. Turner syndrome, and this Turner syndrome is also, guys, cause for chromosomal first trimester abortions. Okay, so guys, that's all for the gynae rapid revisions. So further, if in case you have any doubts, guys, you guys can ping me on the Telegram, or you guys can join my channel FMG with Dr. Talib Bilal, and keep solving questions, give mock test, okay, and focus on the weaker subjects, have multiple revisions, and you got this time, guys. You will pass the exam, and I'll be uploading the PSM rapid revisions in the coming weeks. Okay, all the best, get it done. Allah bless you. Allah Hafiz.